These are the quality outcomes of a number of both palliative care and geriatric models. They improve symptoms, quality of life. In a number of studies, suggest increasing length of life, and we'll talk about why in a minute. Better family satisfaction, better family bereavement outcomes, better physician satisfaction, and a higher likelihood that the care delivered is actually matched to what people want. So, but let me ask you, what is the value equation? Who here knows what the value equation is? Value is quality divided by cost, right? So what's an example of a high value medical intervention? One that markedly improves quality but costs very little. Sorry? Immunization is the classic example, right? Fractions of penny per dose saves millions of lives per year. Okay. What's an example of a very low value medical intervention? Doesn't do much for quality or causes harm and costs a huge amount. What? Yeah, PSA. That's one example. What's another? Now, you know, LVADs prolong life and improve its quality. So whether it's worth what it costs to society is another question, but to the individual who gets it, it's high value. But there are lots of examples of things we routinely do that don't help people and cost a huge amount, like putting people with end-stage dementia in ICUs on ventilators. Doesn't help, doesn't reverse that dementia, does not reverse that constant aspiration pneumonia. All right, so here's the value equation, quality over cost. Virtually every study of these geriatric and palliative care models shows reduced cost. How do these studies reduce cost? Do they reduce cost by saying, sorry, you can't have that LVAD? We're not going to let you have it? How do they reduce cost? By improving quality. They reduce cost not because that is their primary goal. They reduce cost because by improving the quality of care of very complex, fragile, vulnerable patients, they don't end up going to the ED and the hospital. So it's very important to remember that when people talk to you about death panels and rationing. This is not death panels and rationing. This is better quality, allowing people not to fall into the, maw of the ED hospital churn machine. So here's a geriatric model called GRACE that Steve Council, again at Indianapolis, studied. These were low-income, dually eligible seniors with multiple chronic conditions, randomized to receive an in-home advanced practice nurse social work assessment and care plan versus usual care. The quality was improved, better quality of life as reported by patients, families, and physicians, and a $1,500 per person per year savings. Bruce Leff, a geriatrician at Johns Hopkins, designed a program called the Hospital at Home, which identified people who were in the ED and were going to be hospitalized who met criteria for being able to get basically acute care at home. Were they cognitively intact? Did they have a family caregiver who could be there? Did they have any end organ failure? So they were relatively well geriatric patients who could manage. And what it involved, there was a nurse came to the house every day, doctors visited, they got all the same meds. So the outcomes were shockingly positive. People survived longer. 40% reduction in 6-month mortality in a randomized controlled trial, right? So eligible patients randomized to usual care, admission to the hospital versus hospital at home. They lived longer if they got hospital at home. And the total spending was reduced by nearly 20%, primarily by reduced length of stay in either the hospital at home program or as compared to the hospital, and reduced clinical testing. If you're in the hospital, we order stuff on you every day just because you're here. because you feel like you might miss something if you didn't. So that changed a lot. And here's another randomized controlled trial of early palliative care. This was done at Mass General by Jennifer Temmel. Took people who were newly diagnosed with lung cancer, stage 3 and 4 lung cancer, and randomly assigned them to usual oncology care versus oncology care simultaneous with palliative care in the cancer center. Same patients, they either got really good cancer care. Mass General arguably is the best place in the world for lung cancer. Or they got that care plus palliative care. And these patients, no surprise, had better quality of life, reduced major depression, reduced likelihood of being hospitalized in the last month of life, getting chemo in the last month of life. But this study was the lead article in the New England Journal of Medicine when it came out, and was published in the New England Journal of Medicine, not because of any of those first 3 bullets, but because of the last one. The patients lived longer. They lived longer. If this were a drug, if this were a chemotherapy agent, I would be rich. But it's an approach to care. So why do you think in hospital at home, for example, or cancer center-based simultaneous palliative care, why do you think it might be? Let's assume these data are replicated in other populations, in places other than Harvard, in the real world. What might be the mechanism of action for a longer life with palliative care than with usual care? The opposite of what most people think. Less iatrogenesis. That's probably huge. What happens if you're immunosuppressed from radiation and chemo and you go to the hospital? Yeah, you get C. diff and you die, right? What happens if you're a frail older person with, a community-acquired pneumonia who goes into the hospital? Yeah. You fall, you develop pressure ulcers, you get delirious, you become obstipated. The hazards of hospitalization have been well known and documented for decades in older people. So that's one reason. What might be another reason? It's up here on the slide. So reduced iatrogenesis. Needs are being met, but why would meeting needs prolong life? Why would improved quality of life prolong life? I'm going to keep pushing you on mechanisms. You want to live. Yeah, right. So it's really hard for doctors to get that, I have to tell you. Non-doctors, everyone who's not an MD, completely understands. It's like perfectly obvious why a better quality of life would lead to a longer life. Us doctors, we have real difficulty understanding what the mechanism of action for that could be. In fact, I was in Washington, D.C. doing a fellowship when this study was published, and one of my longtime cardiology colleagues was so bewildered by this study. He called me and he said, "This can't be right. Tell me what's wrong with this study." Because we're so inculcated in the belief that if we do it, it must be helping people. It's really hard for us to question that paradigm, that actually much of what we're doing is hurting people. And it's still something that these data are treated with a great deal of skepticism by physicians. Whereas regular people look at me like, of course. I have to also digress and tell you a story about I was presenting these data at the University of Cincinnati about a year ago, and unlike most audiences, there were basic scientists in the audience. Are there any basic scientists here? Not a one. So at the University of Cincinnati, there were 2 or 3 in the back row of the audience, and we were talking about these data and what the mechanism of action might be for a longer life. And actually, we were talking about depression. Because there was a 75% reduction in major depression in the palliative care group in this study compared to usual care. And by the way, absolutely no difference in antidepressant prescribing. So these were oncologists recognizing depression and treating it. But that didn't do it. So this is when the basic science guy stood up in the back of the room and told me about this randomized controlled trial of immunosuppressed mice That was published in Cell a couple of years ago. And in this study of mice, they took immunosuppressed mice and they randomly assigned them to sort of best animal practices, clean cages, safe food. But they were alone in the cage, no toys, no other mice, just food and cleaning the cage. And the intervention group was in a much more social environment. Other mice, toys, chamois claws to burrow under, more diverse food, music. They were talked to by the lab staff. This is not a joke. This is true. This is in Cell. And guess which group lived longer? The palliative care group lived longer. 4 times longer. So it was fascinating to see kind of how stricken this basic scientist was. He said, we sat around and talked about this in our lab, and we looked at each other and we said, we're wasting our life. Because by far the most powerful intervention had nothing to do with drugs. And it was shocking to the basic scientists. So just as it's shocking to doctors. Obvious to regular people. So here's another randomized controlled trial of palliative care at home for the chronically ill. This was done in Kaiser. As you guys know, Kaiser is a staff model HMO with a global budget. So they don't have the fee-for-service incentives to do more to people. They've got a global budget. And in addition to that, they can see if they intervene in one setting, they can see whether that just shifts costs to other settings, right? So they can actually test what happens with different interventions. And what they did, and this was actually 10 years ago or more, was randomly assign people with heart failure, emphysema, or cancer to get home palliative care versus usual home care, Medicare home care, certified home health agency. What are the restrictions on Medicare home care? Gotta be homebound, what else? Gotta have a skilled need, and you gotta improve. So if you're stable, you're out of here, right? Even though to maintain stability, you continue to need the PT, the OT, the nursing, the speech therapy. We're not allowed to give that to you. So that's what the control group got, usual home care. That's the dark blue bar. The light blue bar, you can see they got 3 times as many home visits in the palliative care group. And if you were just running a home care agency in the fee-for-service Medicare world, you'd look at that and you'd say, we can't afford that. Who's going to pay for that? We can't afford 39 visits versus 13 visits. There's no payment for that. But it was Kaiser. So they could see what the impact was on total spending in their system. And you can see that physician office visits dropped by half, ER visits dropped in half, hospital days dropped by 80%, nursing home days by 80%. We can't look at this in the Medicare fee-for-service world. We have no way of knowing what happens when we shift resources from one setting to another. But what did Kaiser do as a result of these data? They do this across their whole book of business. What other integrated health system does this across the country? The VA. Okay, so any rational healthcare system puts the resources where it will meet the needs. But most of us are working in a non-rational healthcare system.